roll in before we get started.
I can't hear you. Am I supposed to be able to hear you right now? Can you hear me? There we go.
Okay,
Yeah,
now my mic. Okay, you know what? That's happened a couple of times. I have no idea what's wrong with my mic. Rewind. Thank you everyone for joining us today. The topic is mental health outreach in campus residences. So just a little bit of housekeeping before we get started. If you've attended our webinars before, you know the drill. Participants are all on mute while we are on the call, so that means you're in listen only. If you have any questions at all during the course of the webinar, please use the question function on the menu to type all of your questions, and Jennifer, who is our speaker today, will be happy to take them up during the session, after the session, because we have about 15 minutes at the end of the session specifically for Q&A. The webinar is also being recorded and it's going to be made available on our website. And the presentation slides are available to download again in the menu. If you click under handouts, you'll get a PDF of the slides. We do have a short survey at the end of the webinar, so please take a few minutes to complete it, as the feedback is really valuable to us. Now, just introduce myself. My name is Prilin Ng. I am the Research and Knowledge Exchange Coordinator for the Center, and we are joined today by Jennifer Kavanaugh. Did I get your name right?
Kavanaugh, yes.
Kavanaugh. Thank you for joining us today. She's the Resident Outreach Worker at Durham College and the University of Ontario Institute of Technology. That's a lot of talking from me. So now I am going to hand it over to Jennifer. Okay, let me pull up her slides. There we go. Is that working?
Yes, I can see it.
Perfect. Okay, take it away.
Okay, wonderful. Well, thank you very much for tuning in. What we're going to talk about today, I'm going to talk a little bit about my background. I'm going to talk about what outreach services is. Then I'm going to talk a little bit about what outreach services really is, what works and what needs tweaking. So if you're really looking at bringing a mental health position onto your campus, into your residence, this will give you a little bit of insight into some areas that I've struggled with, which will then take us into common challenges, strengths, and successes. And as mentioned, questions, you can save them for the end. There's 15 minutes allotted. However, I'm super happy to go off track. I'm super happy to receive questions throughout if you have a burning question that we can address right away. Okay. Awesome. So my name is Jennifer Kavanaugh. I have been in the field for 18 years. I was very lucky that when I started my education, I started working in the field very quickly. So I spent about 4 years in downtown Toronto working at various out of the cold shelters, some for women, some for couples. So my background is very diverse right from the get-go. I have an undergrad in psychology as well as a diploma in social services, and then some random certificates that I've been getting throughout the years. I also spent maybe 4 to 6 years with Durham Mental Health Services, working in their residential program as well as in their crisis program, working mobile crisis as well as phone crisis. Okay, and then I was with actually Canadian Mental Health Association for 11 years, working in all their departments from residential, case management, intake to the ACT team. But most recently, before coming here, I was actually with Canadian Mental Health Association. It was a partnership with Lakeridge Health Oshawa, where I would provide mental health supports in emergency departments. So anybody who came through with came through ER, we would really assess their need and whether or not they would be discharged back into the community or have a hospital stay. So then that led me here. This is my 5th year, 6th school year, located in residence. So I'm actually employed by Durham College. I'm employed by the campus health center, but it's a partnership with Campus Living Centers. So I'm actually in the student residence is where I spend the majority of my day. So we'll just go to the next slide. So what is outreach services? So I'm going to talk a little bit about the early years and how this position actually came about. So this role was developed because resident staff was realizing they were starting to see an influx of complex mental health issues. They were seeing suicidal ideation. They were seeing a lot of depression, anxiety, a lot of odd behavior, so to speak, that they really were not sure how do we deal with it. And they realized it was very much a reactive approach. There was no prevention, and there wasn't anybody in residence equipped to be able to manage these complex behaviors. They started utilizing an outreach worker that was stationed in the campus health center. So keep in mind that it's a multifaceted, it's a doctor's office essentially. So it's much more of a medical model. We'll talk a little bit about that later. But there was an outreach worker working for the campus health center located in the campus health center. So they would utilize her sometimes to come into residence, to do some events in the lobby and to work one-to-one with the students. Then they hired a part-time person who I believe worked about 3 days per week from about 6 to 10 p.m. But they were realizing that it was a benefit. However, they were still seeing a lot of these complex behaviors that, of course, were happening outside of her hours. So then a full-time position came up in August of 2013, which is when I started. Does anybody have any questions about kind of the early years and how it started? How or why?
Can wait a couple of seconds, see if anyone wants to type in any questions.
Okay.
Okay.
So we'll move on. So here's what Marcus Landis, Residence Life Manager, had to say in regards to the position. So I'll just read from the slide here. Prior to the residence outreach worker becoming full-time in the role, we were still finding ourselves frequently encountering students in crisis whose needs were beyond our expertise. Once the outreach worker was with us full-time, the amount of students staff had to deal with in crisis was drastically reduced. We went from having 2 or 3 threat assessment meetings every year to 0. Her presence was like placing a release valve on the students' needs. She was able to intervene prior to students reaching crisis. It became a real game changer for us and our ability to support students and keep them safe.
We actually have a question for you here.
Yeah.
How many beds are in the residence?
There is, we have 2 residents, and between the 2, there's about 1,350.
Awesome. Hope that answers the question.
Yeah.
Do we want to move on?
Yes, go ahead, please.
Sweet.
So what is outreach services? So in a nutshell, it's student directed, as we'll see most mental health supports are. The focus, again, is really working with students in residence regarding any mental health concerns. So that may be students coming in that already have a diagnosable mental illness. This may be students who are in their age of onset that are developing symptoms of mental illness as they're coming in. But aside from the illness piece, we know that we all have mental health. So I'm also working with students that are experiencing mental health concerns, the inevitable challenges that come up with dealing with being away from home for the first time, dealing with new challenges and timelines and relationships and all of the struggles that they are going through. It's also not just the one-to-one. A big piece that I've learned over the years, and again, we'll get into this later, is the prevention piece. The prevention piece where you will see me out in the lobbies, really making this a a culture of mental health well-being, where people kind of walk in the lobby and they're already feeling supported because of the messages that they're seeing posted, because of the people that they're seeing constantly through the residents that are really promoting that sense of well-being. Okay, as well as offering support and education to staff and students in residence. Yes, mental health is my job, my description. However, when we look at mental health, as many of you would probably agree, it's very much a community issue. So it's also about equipping the staff with the ability to kind of provide that triage for when I'm not here. Okay. So what I've done here is you'll see what is outreach services. I've literally taken my job description and laid it out here. It's a little bit summarized, but what they have is, and I'm pretty much just going to read this straight, one-to-one supportive intervention and or making referrals upon assessment. That is about 30% of the time is what they're saying. Okay, here is assessing students' mental health status, including consulting with a physician. Okay, so a key component here is consulting with a physician, which they're saying is 25% of the time. When we're looking at developing a job description, this was developed when the outreach worker was in the campus health center. So it's much more medical, and not everything necessarily fits over here in residence. Okay, when they had the outreach worker right beside the physician, they were able to utilize the outreach worker a little bit different. So if the physician was very busy, they would be able to kind of give the instructions to the outreach worker to then pass along to the students. So they were able to work a lot more closely, whereas there's no chance that I'm spending 25% of my time consulting with a physician. Okay. Maintaining client records in confidential manner. So apparently record keeping is 16% of my job. We look at provide mental health promotion to students, faculty, and staff on mental health, which is 15%. Composing letters supporting OSAP application, counseling attendance. So I do have the ability, if a student is in mental health distress and they have missed an exam, they have missed an assignment, I do have the ability to, on letterhead, just write them a note to be able to send that to their prof to so then they can basically make up the work that they had missed or the test that they had missed. Okay, responding to traumatic events takes up 2%, as well as participating in committees. Explaining physician instructions to patient, student, 3%. And then the last 2% is first aid emergency response, arrange transportation to hospital where appropriate. Any questions pop up?
Yes, we just had a really quick question for you. Which university are you located at?
So UOIT, so the University of and Institute of Technology. University of Ontario Institute of Technology. Okay, what really is outreach services? So we'll go right to the next slide.
Okay.
Yeah. And then if you want to click it one more time, I think.
Ah.
Yeah. You can click them all, yeah. Oh, 345%, look at that. Okay, so this is the reality of what I'm doing. Mind you, the error under traumatic events on campus, it's showing 345%. So we look at what I actually do, one-to-one support, I would say is 28 to 84% of my time. Okay, I would also combine the one-to-one supportive interventions and assessing students as one. Excuse me. My referrals are minimal. When students are already coming to see me, what is happening is the majority of these students are already connected. They're already connected to OSAP, connected to financial aid. They're connected to Access and Support Center. This is for the most part. The majority of my referrals are indeed going back to the doctor. So if a student is presenting with me. Either they already have medications and they want to refill them. If they're asking for a doctor, then my system is connected to the campus health center, so I'm able to book them an appointment. That would be the majority of my referrals. The other piece, if a student is exhibiting a lot of distress or signs and symptoms of depression and anxiety, I get them to fill out the PHQ and the GAD-7. Excuse me. In which case, then I'm connecting with the physician. Other times I will connect them to access and support in other areas of the campus, absolutely. However, I'm more giving them the information and then they're taking it on themselves. During our next appointment is when I will check in to see how those supports have played out for them. So big focus is on really building that empowerment and them taking the initiative to really access the supports that might be best for them. So assessing and consulting. The assessing is happening all the time during my one-to-ones. It's a constant 100% of the time when I'm working one-to-one with students. Again, the consulting piece is a very minimal piece of what I've experienced thus far. There are many times where I have gone with a student to the doctor where the student is not very clear on articulating what has been happening with them, or they may be nervous due to past not so great experiences that they've had with physicians in the past. So I have gone in and I've advocated for them. Or if the student is going in on their own, I've consulted with the doctor ahead of time. However, even that is minimal because my notes are connected with the campus health center. All they need to do is pull up my notes and they will see exactly what happened and any referrals or anything that I've been doing with them. Record management about 10% of the time, and that is basically my note taking. Okay, so after seeing every single student, it goes into the system, and as I said, the doctors have access to that. Mental health promotion, there's a huge range here. So it's literally between 3 to 42% of my time. And that range is so high because my focus is the one-to-one support with the student. Most recently, that has been higher than other years. So unfortunately, my promotions have gone down a little bit. But ideally, mental health promotions, I'm doing a little bit more than that 3%. And the mental health promotion is really about me being out in the lobby, doing things from painting gratitude rocks to, we do letters to future self. We do a lot of different events. Sorry, did you have a question?
Oh, yes, actually. Somebody asked, can you clarify what you mean by supportive interventions? Does that mean that you're providing ongoing one-on-one therapy appointments, so CBT, and those kinds of things?
Sure. Where does it say support? Oh, okay. One-to-one supportive interventions. And again, that's the way that it is documented in the job description. So that is really looking at working one-to-one with students and then providing any interventions necessary. That might be referrals to doctors, or yes, as you're saying, I use a lot of CBT forms, journal writing. We use forms for strength building, really depending what is happening with the student. So typically every student, most appointments go home with some type of homework that they're working towards. That also allows me to see what their level of engagement is. I hope that answers your question. If not, then ask another one. So where were we? Mental health promotion, letters of support is less than 1%. Like I said, it's a handful of times that I've had to write letters of support with students. Traumatic events on campus is obviously not 345%. I put that in so high so I wouldn't forget to change it, and I did. Again, that's probably less than 1% of the time. Then we look at committees. So to be honest, I don't have a lot of time to be on committees in the campus. What tends to happen is a committee pops up, I'm super excited, I'm not so busy, I sign up, and time just passes and I haven't gone to and really been part of it. A few that I have been, but again, it's quite minimal. I sit on 2 committees out in the community where we have all of our community partners that come together. One group is on youth suicide prevention, where we connect with the distress center. We do a walk for suicide prevention. We also help in developing and promoting the Be Safe app, and we really look at how do we reduce the amount of suicide and the impact of suicide on our community. I also sit on another committee, the Healthy Sex Youthality, where we are going into high schools and talking about safe sex, safe partying, girl talk, guy talk, bringing in a speaker from the LGBTQ community. So we're really doing the outreach piece, but again, that is out in the community and not so much on campus. And position instructions, very minimal. So less than 1% there.
Cool. We have another question for you. We are trying to run health promotion events similar to the ones you mentioned, but we are having trouble with getting students to come out. How do you get students to come out?
Yes, that is a forever challenge. One, I would like to know, what are they already doing? So looking at what they're doing and what piece is not working and what is working, and then start to maybe emphasize the piece that is working. What do I do specifically? So it depends. So there's quite a few things. So I run an event every single month in my office. So that ranges from stress management, making meditation bracelets, journal writing. What else have we done? Vision boards, motivation boxes. So I do a variety of those things once per month. There's not always a lot of attendance. It ranges from 0 to I've had up to 14. 14 is by no means the standard. I would say the standard would be about 2 to 3 people. I keep that going regardless of the numbers. I commit 1 hour, one time per month for a smaller group that's held in my office. We also do once per week a event in each lobby of the residences. We do them in the lobby because that's how we increase the engagement. So in past, I did like a breakfast group where we met in the kitchen and we were going to cook breakfast. I brought all these things and 3 people showed up. What we did with that is we got all of our stuff and we took it out into the lobby, and that's how we connected with people. So we really let go of that idea that we need to huddle and have this big group of people. And we changed it to maybe we're going to reach more people and be just as effective if we just get them as they're going by, right? So as students would walk by, we'd say, here's a package of oatmeal. Here's what's healthy about it. Here's some juice. This has no sugar. Try out these new granola bars. Have you had breakfast today? So we would stop students and engage them as they were walking by. So that would kind of be one tip. Also the advertising. For advertising, I am we have a Facebook group. So I have a professional Facebook account, if there's such thing, but it's not my personal Facebook account. That's what we'll call it, where I'll post all of my events on there, as well as I post flyers throughout the building to let people know what's going on. And again, I've lowered my expectations in terms of how many people need to show up and really brought stuff to the lobbies. The other piece of the promotion is really the optics of it. There's a sense that people feel supported when they are walking through the halls and they're able to grab a positive note. When they're walking through the halls and they see, hey, come see the outreach worker, there's a group on anxiety. That in itself says, wow, there's a group. I feel supported. Okay, so I hope that answers your question, and we might answer it a little bit more as we go on. You want to connect to the next piece?
Yep.
Okay, Okay, so here is, so I put statistics together every single month. What I kind of liked about my job is that it was always part-time before I came on. So when I started, I was really able to develop it to, although I have a job description, as you see, I don't totally work within it, and I'm okay with that. I was really able to develop what it's going to look like, and even stats. I didn't have my boss saying you need to provide stats or this is what we need. I just fully developed that on my own. And the stats was really not necessarily, wasn't policy driven. It was more, what do I need to know? What information do I need to do my job better consistently month after month? So here is an indication of what I saw in September. So 42, I think I saw 51 students one-to-one in September. 42% they're presenting concern. So I'm not talking necessarily about a diagnosis. This is their presenting concern. Anxiety was 42% and depression 16%. This is the biggest divide that I've ever seen. This is my 6th year being here, and this is the biggest divide. Typically, they're about 50-50, but anxiety and depression are always the highest. Relationships 3%. Typically, that's also a little bit higher. Seeing students regarding to symptoms of autism is 4%. Overall well-being, I put that in there. I have a handful of students who things are going fairly well. Things are going okay, but for them, because again, this is student driven, so I'm not focused on there needs to be mental illness. These are some students who are maybe lonely, they're isolated. Things are going well overall. There's no diagnosis, they're functioning, they're doing quite well, but for them, it feels good to come in and vent. It feels good for them to come in and just have a checkpoint. So these are the students who don't typically have the same type of homework. They're not going home with CBT forms. These are typically shorter check-ins. Substance use, 1%. I've never seen substance use it has not been presented as much as it is actually a problem. And that is probably because students feel like it's very normal and expected that they're using during these school years. So I still do run events regarding substance use. I run them around St. Patrick's Day. I run them around before Christmas, the beginning of the year, where I'll do safe drinking demonstrations and whatnot. But I've never seen substance as much as I should be seeing it. So my role there is when I know that it's a problem, but I'm not seeing it, the best I can do is just do awareness. Self-harm, so these are students who are self-harming. That's 6%. Students coming in with academic concerns are 9%. Academic concerns, there's always a referral typically attached to that where I'll send them to the Academic Learning Center, let them know kind of what their resources are in residence and on campus. Nutrition, 3%. And then suicidal ideation, 10% of what I was seeing. Anybody have any questions about this chart? No?
We
Okay,
might get to later.
Yeah. Some of the events that I took part in September. So you'll see, and things pretty much are the same from year to year for the most part. Again, it's student driven, so it really just depends what I'm seeing. But there are a few things that I can anticipate in terms of what events that I need to be running. So the beginning of September, there was a transitioning to post-secondary. So for that, I wanted, my original plan was to have it in a lounge or in a separate room. But again, I knew that I was not going to get enough students. So what I did is I just went into the lobbies. In that case, I'm probably hitting 100 plus students every time I'm in there. So I did an event on transitioning to post-secondary. We have therapy dogs that come in every single month, which gets us again at about 100 students at each res buildings with the therapy dogs. I also take that opportunity. I've got pamphlets, flyers discussing outreach services. So I take that opportunity to talk to the students about the purpose of having the therapy dogs and what my resources, what my supports entail. I'm a certified yoga teacher, so I teach yoga in the student residence as well. Participate in a walk for suicide prevention. So you'll see duplicate events, and that is simply because what happens in one building needs to happen in the other. Looking at bucket list for yearly success, so getting students engaged in terms of, by the end of the year, how do I know that it was successful? What am I trying to work towards? Creating vision boards, letter to future self, as well as teaching safe talk. So that really covers a part of the job description, which is supporting and educating our staff members. So on a regular basis, I also teach safe talk, suicide alertness for everyone, as well as mental health first aid. So we can go to the next slide. Okay, so let's talk about what works and what didn't work. And it's not so much about what didn't work as much as it's what needs tweaking, okay? So what is working? So I ran a successful book club, and I'm just in the middle of starting another one. I tried to run a group on depression and anxiety. I felt that there might have been a need for it because a couple people were asking for it. However, each time that I tried to run these groups, students didn't want to come. Again, policy-driven, people really like to know that you're offering these groups. So I did. However, this age group does not like groups. They don't like groups where you sit around and you talk about your depression and your anxiety. Most of the feedback that I've heard from students is that's just not what they're looking for. They don't want to sit around and listen about people's anxiety, and they find that it can be depressing. Okay. However, I do see value in bringing people together. So that's where I had to get creative and say, how can I do this? So I started a book club, and we read, pardon my language, The Subtle Art of Not Giving a Fuck. Students loved it. It very much targeted the students. It's a very trendy book, and we were able to look at how it impacted their life, what their aha moments were, and in each of those students, some anxiety and depression conversations came out. But beyond that, the conversations were about, how can I do better? I didn't realize that I was like this. I didn't realize this, and here's what I'm doing to move forward. So it was very similar to a depression and anxiety group, just a little less formal and a little bit more trendy to what works with the students. What is working and what is not working is mental health ambassadors. So I pulled together a team of students who really could be leaders in mental health. And the role was really about promoting mental health well-being through their social media platforms, as well as supporting me through some of the events. So their peers could really be out at some of these events. I say it's working and not working because with the strike that we had last year, a lot dwindled. So the ambassadors were more focused on social media rather than in person. So I'm tweaking that for this year, and I think 4 really good ambassadors that will come out and be student leaders. Engagement can be difficult on campus, but especially in residence, because these are students coming in for their very first year. I personally find them a little less engaged than some of our second, third, fourth year students. Work study student. So what I was realizing is that so much effort was put into the one-to-one, which is the biggest focus of my job and very important. However, there's also a lot of importance in terms of creating this awareness and this culture throughout residence. So I have a university work study student that is dedicated to mental health support and promotion. I shouldn't say support, mental health promotion, 10 hours per week. So her role is to really engage the students and to facilitate a lot of the events that we're running in residence. Other things that work are flyers and posters. So some years I've done monthly themes. So this theme might be around anxiety. So I'd put a lot of different posters throughout the building on anxiety. Other posters that I'll put on is just advertising different groups, different events. I'll put positive quotes, different things for self-reflection to get students thinking, as well as hopefully getting them engaged. Welcome letter each semester. So again, these are things that I've started to develop through the years where I was like, how can I get more students in to see me? How can I reach more students? It's easy to reach the students that are willing to come for help. What we really need to focus on is how do we fill those gaps? How do we fill the gaps of the students who are isolated? How do we support the students that don't want to come to events? How do we reach them? So that is about getting creative. And one, the better that you equip your residents, the staff, and other students, that it is also their role to support, then everybody has the eyes and ears and looking out for other people's wellness. Several times I have students coming to me that they're concerned about their roommate. So then I'm able to get in there and support that student as well. But going back to the welcome letter, it is just reaching out to every single student that lives in residence, just welcoming them to the campus for the first time or returning back, and just letting them know about what my services are and how they can reach me. My favorite, I hate to love it, but there is a life-size cutout of me in the doorway of each residence. And then there's a little bubble where I can write how to contact me and whatnot. And then there's a little table where I have brochures. So again, students are constantly seeing my face or my work studies face, and they are seeing outreach services every time they walk in the building. What's working is flexibility. So my hours are Monday to Friday, 10 to 6. I also have, you'll notice the last one under needs tweaking, as hours work and they don't work. Hours work because it's super flexible. I can work the overtime, or I can come in late, stay late. Sometimes I'll work on the weekend. Why I say the hours don't work is because I would probably embed that in the job description to at least have one evening shift per week. I put lots of question marks because I don't want to be the one working that late shift per week. However, I am flexible when there's a need. You will definitely see me here. Events are working, as I mentioned before, therapy dogs, and I mentioned before running some informal groups. And just back to needs tweaking. We talked about it, depression and anxiety groups, talked about mental health ambassadors. The other thing that needs tweaking is booking appointments. So right now, the way that students book appointments, and by far the most utilized, is the students reach out to me through email. They have found out about my services through my life-size cutout, through the posters that are embedded and throughout residence, for me in the lobbies, from my brochures, and from me being on Facebook. That is how students find out about me as well. The RAs that are constantly referring students to me. So most of the appointments are done by email. They're also welcome to call me. They're also welcome to walk in at any time. The reality is I might be with a student, so it's best to pre-book, but they can also walk in. Where I find a challenge in terms of booking appointments, there's a benefit because I'm connected to the campus health center. There's a benefit because the campus health center can book appointments on my schedule, and I can book appointments for the students to connect with the doctor. Where it becomes a challenge is because we have two buildings. So when I'm over at the Simcoe building and all of my materials are here and my computer is here, I can't really book an appointment. Okay, when the students are RAs are meeting with a student that they want to refer to me, or the staff are meeting with a student they want to refer to me, there is not a real seamless way for that to happen. It's not really easy for them just to book an appointment. Instead, what they're doing is they're telling the student to reach out to me or emailing me with the student's information so I can then get back to them. What would be ideal is to have like a mobile system that you can carry with you, that if I was sitting in the lobby and I met with a student, that right from my phone, I could book an appointment. Some things that we have done to sort of manage this is during the events, I have printed out my availability on a schedule, printed it out and just placed it on the table where the event was, and allowed students to sign up that way. I've also posted my availability outside of my door on a whiteboard. Didn't really address the issue because students weren't really signing up, so perhaps that says it's not an issue. Another tweaking is we do a ballot box for when students move in. So basically, every single student that gets every student gets a move-in package. They also get a kind of like a postcard with my information, my contact info, and then they put it in a ballot box, and they can win like $250 from Walmart, massage, physiotherapy, a lot of just different wellness prizes. We put a lot of time and money into that. And I get between both buildings maybe 50 students. So it's really important to look at how much time and money are you investing in something when the return is low. And I talked about hours. So is there any questions about this slide about what's working and what really didn't work? No? Okay. Let's move on. So common challenges.
Oops, sorry.
Okay. So common challenges, I already talked mostly about this. The booking of appointments can be a bit of a challenge. You know, I say that, but it's still pretty much working because the students are reaching out to me through email. But I would like more seamless so that the students, student leaders, the RAs, as well as the staff, when I'm not on shift, I would really like to be able to see them being able to book an appointment to come and see me. Common challenges is multi-residences. We have 2 residences where ideally I would spend way more time in the other residence. I think in 2 months, I've been there 3 times. So ideally, there will eventually be another outreach worker in there. That is what I'm crossing my fingers for. But students from the other building will come and meet with me in my office. I do have some students who are dealing with some more complex mental health issues that I want to ensure are getting seen. I will go and meet them over the other building. Team dynamics. That is a challenge. Because I'm employed by Durham College, I'm employed by the Campus Health Center. However, I'm in the student residence, the only one doing mental health support and the only one employed by Durham College. So essentially I have 2 teams, but I'm also a little bit owned by UOIT as well. So I kind of have 3 teams, more so 2. So I'm kind of pulled and sometimes not part of any team and can work very much in isolation. There's definitely pros and cons to that, but it takes a lot of work to ensure that the connections are being made everywhere and that I'm still connecting and being part of the health center. Otherwise, it can be very isolating being the only one here. Role with the RAs can sometimes pose as a challenge. To develop this position, I would get very clear in terms of what is the mental health worker, what is the outreach worker going to be doing with the RAs? What is the specific role? Because right now, to be honest, it is not very clear. Res Life, for the most part, is, for the whole part, they are taking on their wellness checks. They are doing their one-to-ones. There's nothing saying that the RAs have to debrief. Granted, you can't force them. It would be really nice and I think imperative to embed that piece into the job description and the expectations from Res Life and the residents as a whole to fully utilize the outreach position. Because what you can start to get is the staff that start to take on a counseling role, which can then start to hinder the work that you've already done with certain students. So it's important to draw that clear line between Res Life, outreach worker, and RAs. The other part that can be difficult is the RAs start at 6 p.m. and I'm done at 6 p.m. So there isn't always that the strong connection simply because of hours. With that being said, I do attend the RA conference. I do some of their training, and I'll send out just some emails just reminding students, RAs, to touch base with me. Yeah, that would be it for now in terms of the role with the RAs. I think there was something else, but I can't remember, so we'll keep going. And the next slide. Oh, I've lost you. There we go.
Can you hear me now?
Yes.
Sorry, that was me. I forgot to unmute myself. Can you explain the rationale for your position being connected to the Student Health Center rather than the Student Mental Health Services Department at UOIT? Is there a mental health services department at UOIT?
Yes, yeah. They have a fantastic mental health service program. I don't know. Well, the Campus Health Center, they are the ones that just started it. I think with this position specifically, I'm in the student residence, and the student residence, we are the campus is a shared campus, as you know, so we have both DC and UOIT. So for me to work with both Durham College and UOIT, I would have to be connected. This is my understanding. I would have to be connected to a service on campus that serves both. Because right now what we have is separate services. So there's an access and support center for Durham College and student accessibility for UOIT, whereas both students as of now can access the Campus Health Center, their psychiatric nurses or the doctors or outreach, right? So if I was part of UOIT mental health or part of, Durham College wellness coaching, then my guess and my understanding is then I would be servicing just Durham College students or just UOIT students. So I'm one of the rare services that are for both institutions. So if you're looking at bringing an outreach worker into your campus, I don't think it necessarily has to be with, if you have a campus health center, under mental health services makes total sense. I hope that answers your question.
Okay, so I guess we'll move on.
Strengths and successes, impact of the role. I've talked a lot about this. My focus is really about, and I don't have to talk much about this because as I understand, there's a lot of mental health workers that are tuning into this, but my focus is not trying to get rid of their stress, not trying to get rid of their depression and their anxiety, but really helping them build a capacity for resilience, helping them understand what their triggers are, helping them build coping strategies so they can manage when these signs and symptoms show up, and then how to relieve them even if they can't take them away. Comes very much from a place of coping, resilience, and empowerment. It is non-clinical, it's less formal, as you noticed from my job description. A lot of times the students are coming in their slippers, their sock feet, and their pajamas, and it's really nice to kind of be in their home. It creates a safe space. The constant feedback that I get is that they feel good in the office. I have a Himalayan salt lamp. I've got doodle things on my table. I've got couches. It's really creating a space for students to come in and just be and to feel welcome and to not feel that they're coming from a place of illness. Strengths and successes. Confidentiality was a struggle at the beginning. Confidentiality was a struggle because the residents would get quite concerned to find out that I had a student on a safety plan. It took them a while to really realize and be able to step back and say, okay, I trust this process, because this is student driven. This is student confidentiality. They have a right to, for me to hold that space for them. You know, if they're in immediate danger for self or others, of course I need to contact somebody else. I need to contact emergency services. But students who I'm working with and creating safety plans, residents doesn't always know that. They don't always know what is happening, and it's that the student's right. With that being said, when I kind of assess that maybe the staff really need to know this, I work with a student in terms of empowering them to make that decision if they want staff to be aware of what they're going through and if staff could be a support for them. But for the most part, the students want it to be separate from what's happening in residence or from the staff in residence. And I think that's the final slide. Yes, any lingering questions?
So we're going to open it up for questions right now. If you have any questions from the slides, from whatever Jennifer was saying, feel free to type them in that little box. We have about 10 minutes for questions. Okay. Related to your last point, how are you able to coordinate support for particular students and communicate with residents, professional staff? What has worked? Where the student allows, disclosure forms, regular meetings with professional staff.
Say that last piece again, sorry.
It says where the student allows. Example, disclosure forms, regular meetings with professional staff.
Yeah, so I will often ask at the beginning when I'm meeting with a student, is there anybody else that you want me connecting with? So I have some students that I speak to their parents on a somewhat regular basis. So I have them sign a consent to disclose. I have other students where I'm connecting with Access and Support Center or coaching. So that student has signed a consent to disclose. If a student is popping up a lot in residence in terms of a lot of person of concern or incident reports, I will talk to the student. They know that this is happening, and I would talk to the student and just say, listen, staff are quite concerned. Here's the information I would like to give staff so they know how to best support you, in which case I would say 99.9%, if not 100% of the time, the student has been more than willing for me to disclose as on a needed basis to some of the staff and residents. And that's more so for the student benefit, because if a staff doesn't work in mental health, some behaviors become very alarming. However, they don't need to be alarming. So that's where it is helpful for me to be able to discuss some students with staff, so I can say, this is when you need to be alarmed, and this piece is okay.
Okay, hope that answered the question. If anybody has anything else, feel free to jump in.
If anybody has any specific questions about their properties, or something comes up at a later date, feel free, I should have put this on the slide actually, feel free to send me an email or give me a call. I'm more than happy, and I've done this with other campuses, to discuss one-to-one with you some more specific questions you may have.
Do you know of any other campuses that have something similar in their residence?
I know Mohawk has a campus. I'm not quite sure if she's embedded right in the residence. Queens, if I'm not mistaken, I've spoken with them a few times. I believe they're in the residence. I'm not totally sure, to be honest with you.
Mm-hmm. So where would you classify your jobs? Like your kind of health promotion, a little bit of that front line. Where would you put yourself into the buckets?
I would put myself frontline. I think part of that, the mental health one-to-one support or mental health support is not just that one-to-one. And I think that we need to shift our thinking and really have it encompassed as everything, because that the events and being out in the lobby, that informal piece has been imperative to my position. They have been able to put a face to the person that they are going to be connecting with. They are able to relate with some of the messages that I'm putting out there. So it's very much the promotion and the one-to-one support is very much intertwined as one.
You know, you're right. That is so important. Like having, like one of the steps being that for students to be able to feel comfortable coming to you with issues is that they need to feel like there is a connection, and it's not just they're going to be sitting down in a very cold clinical setting and talking about things that may be very personal.
Yeah, and you know where to really. It's a real opportunity to work with this age group. It's a real opportunity. Coming from doing a lot of community mental health, working with a lot of complex behavior, a lot of that you're kind of forced into reactive and postvention. Opposed to here we are, we really have this opportunity to work with students and the prevention piece. And that is just as important as the one-to-one. They get so much benefit from these informal groups, from these informal events that are happening. And they also build connections during that piece as well.
Yeah, that's true. And it reminded me of what we were chatting about the other day, in that it's very interesting, like doing mental health related things in residence, because that cohort changes every year. And in a way, there's no continuity. So that's very unique in a way.
Yeah, and like I said, there is a few things that we can always anticipate. Transition is hard in September. And then in October, all relationships end. They thought they were going to get married, but unfortunately, these relationships have now ended. Then in December, every single year, I have seen between 9 and 11 students, because students are prepping for exams, writing exams, and they want to get the heck out of here. So I'm not seeing a lot of students in December. January is always very busy. I've got a flood of emails before even coming back from holidays. Students have received their final marks. They didn't do as expected, so it's very challenging. February, we're always working on the winter blues. That is the constant message. And then April, again, I hardly see any students because they are looking to book it out of here. So there's a few trending patterns that always happen, as well as we've got, you know, we have Halloween, we've got St. Patrick's Day. So there's a few holidays that can sort of drive our messages as well.
Yeah. Well, let me see if there are any other questions. No. So anything else that you'd like to add, Jennifer?
I hope you learned something. I would strongly recommend having this position in residence. Even being here, the residents will say that there's less crisis. There's not less crisis. I'm just seeing them all. But it is working. It is working because students, I think a couple of years before coming, I think 5 students were evicted for concerning behaviors, complex behaviors. This is getting dealt with before it gets out of hand. Students now more than ever really need the coping strategies. They need that prevention. They need that support. And just to be right here, every day that I'm here, it's a genuine privilege.
Well, thank you for that. And thank you for your passion and your dedication.
Yeah, of course.
Well, and thank you to everyone who has joined our webinar. Our next webinar is in November, and it's on Indigenous counseling. So don't forget to take part in the survey that's going to pop up. And one more thing. Sorry, not for you. Not for you. For our general listeners. One more thing. For people who have signed up on the webinar, we're going to be introducing these letters of participation. They're going to go out in the post-webinar email, so you get kind of like a little kind of a little sheet of paper saying that you took part in the webinar and you have your professional hours if you need them for any sort of training. So, okay, well, thank you, Jennifer, and thank you everyone for tuning in.
Thank you so much for inviting me. Thank you, everybody.